Hey everybody, it's Julie again. It's Thursday, one day closer to Friday. I'm officially doing a countdown, as you can tell. For those of you that checked out our knee workshop last night, I hope you kind of enjoyed learning a bit more about how your knee functions, how it moves, the mechanics, and why things can have an impact. Tonight is going to be a short little talk about our hip joint. And why we're talking about it is some people have hip pain, but a lot of people have low back issues, knee issues, any sort of lower extremity issues. And it's really common to have some restrictions or issues going on in your hip joint that could actually be causing some low back issues or knee issues like we talked about last night. So if anybody does have any specific hip issues, make sure that you feel free to comment in the comment section. And if you were here last night too, can you please throw up a little heart or something so I know that you were here 2 nights in a row, which is awesome. Now, for those of you who have suffered from hip issues, there's a variety of different conditions that you can get within the hip joint. Anything from, we see people in the clinic with a bursitis. So if you guys aren't aware what a bursitis is, it's basically an inflammation of a bursa. And a bursa is kind of like a balloon, I guess you could say, like a little sac that protects muscle over top of a bone. So if a muscle comes in contact with bone, it's really common to have a bursa underneath it just to give it a little bit of support so that the muscle isn't constantly frictioning against the bone. So we see bursitis in the hip. We also see, we see your typical hip fractures, hip replacements. What we see occasionally and intermittently is hip labral tears. Labral tear is basically kind of like the tissue that surrounds the hip joint. We'll talk about that in a second. And sometimes you can have a small tear in the labrum. We also see hernias that can be, inguinal hernias, pretty common as well. Your typical sprain or strain to the hip joint. So you pull a muscle, pull a ligament. If you're playing soccer and you kick the ball too hard, or you're playing hockey and you go to push off and you've extended too hard, whether it be your hip flexor, your hamstring, that sort of thing. What I see most commonly in the clinic is snapping hip. I'm not sure if any of you guys ever noticed that your hip pops or snaps in the front or on the side with certain things like running, or if you're doing an ab workout and you're doing leg lifts, or even just with walking. You can have like an anterior or a lateral snapping hip. And what I see a lot of is what we call an FAI. It basically stands for femoral acetabular impingement. And it's just a pinching that occurs in the hip, but can happen for a variety of different reasons. So those are some of the kind of common conditions that we see. And then, your traditional tendonitis where a muscle gets irritated, overused or underused, weak or too tight sort of thing, and you get your typical inflammation of the tendon. So does anybody know how the hip functions? Does anybody know what type of joint it is? I know it's such a hard question, eh? So your hip joint is a ball in a socket. Now, if you remember, we talked about another joint that was a ball in a socket a couple of weeks ago, which is your shoulder. The shoulder and the hip they're very similar, and they have a number of common factors and features that they have. But the shoulder itself is basically to provide like a stable base for a wide range of movements, especially for the upper extremity. Now, the hip joint its main structure is kind of to provide stability and mobility for the entire lower extremity, because it's basically taking the load of our entire upper trunk, right? And if you think about it, it's actually a lot of weight, right, to take through a joint. So that area it has a variety of strong bones, a variety of really strong muscles, or we should have strong muscles, strong ligaments, and then the ball in the socket itself is a really deep joint. So we're supposed to have a lot of mobility in that joint, but also a lot of stability. Now, if you guys don't know, but the hip joint itself has, I believe, anywhere, I think it's 17 or 18 muscles that help to move the hip. And your hip has a variety of different movements that it actually performs. And if you think about it, then you can actually assess and say, hey, am I having restrictions in certain movements, or do I have full range of motion? So to break up the movements, there's basically, four primary movements. So you've got your flexion, which is your knee up to your chest, right? You've got your extension, which is the ability of your entire femur, which is your thigh bone, to go backwards, right? You've got abduction, which is the ability of your leg to go outwards. And then you have adduction, which is the ability of your leg to go inwards. But and then we also have the component, because it's a ball in a socket, it has the ability to rotate, right? So you can actually rotate out, so that's external or out, and internal, which is in, right? And we'll talk about that in a bit. But so if we talk about how the hip joint is actually situated, so the socket is actually part of your pelvis, right? So you've got your big pelvic bones on the side. So the socket is actually part of your pelvis, and that's called your acetabulum, okay? And then you've got your actual ball. I'm not a good drawer, remember, okay? And then you've got this little jet out of bone and then down. So this is the ball, which is your femur. This is called your femoral head. And then you've got the acetabulum, right? So because it's a ball in a socket, it's really easy for that ball to flex, extend, abduct, adduct, externally and internally rotate. Now, what we have to remember is not everybody's hips are shaped the same, okay? And what I mean by that is the angle of your femoral head, and this part's kind of called the neck, and the femur can actually vary amongst people. And you may have one hip that's different from the other hip. So the angle that they have here also has a huge impact on how your hip moves. So you could have, more of a 90-degree angle, or you could have more of a 120-degree angle between that neck and that head and the femur. Okay, so this has a huge impact on how much range of motion you have. Now, we were talking about bursitis. So people who have a hard time laying on that side at night, there may be inflammation of a bursa. So see how this bone jets out here? Okay, that's your, there's a little bursa that sits over top of this, because you've got a couple of glute muscles, and I'll do those in blue, that kind of come around and attach down here. So if that bursa wasn't there, what would happen is these muscles would actually rub against that bone, and over time it wears it. So it's really easy for this bursa to get inflamed if we don't have good flexibility and mobility of those muscles and the tissues in the hip joint. Okay, so that's typically your bursitis that you'll see. Now, snapping hip, which we talked about, when you lift your leg, if you get a click or a pop when you move your leg in certain directions, you can get, there's actually about 3 places that you can get snapping hip. So your glute max, which is that big muscle in the back of your bum, it actually can rub against this bone, as well as your IT band, okay? So your IT band that kind of runs down, that tissue that runs down the leg can rub. The glute med coming from around the back to attach can rub. And then you have your hip flexor. So the muscle right in the front aspect of your hip that lifts your knee up towards your chest, that can also rub. Now your hip flexor is called your iliopsoas. So it's a muscle that it's kind of two muscles. I'm getting kind of complicated here. There's two muscles in the front aspect of your hip that one of them actually attaches to the pelvis. The other one actually goes through your abdominal wall, through your stomach, and attaches to the back part of your spine. That's called your psoas muscle. So you'd be surprised how many people I see with back pain that have a tight hip flexor. And that can honestly be one of the major contributors that I see clinically to hip pain and low back pain. So that muscle can kind of click over a couple of different areas. It can, in your pelvis, you've got this little eminence. It's called your iliopectineal eminence. It can click over that. And then it can click over this area as well. Basically the femoral kind of neck or the femoral head area. So right up in here, it can click if it's rubbing back and forth. So if you have pain in the front of your hip, it can commonly be a hip flexor issue, like a tightness or a weakness, or you could have an impingement. And a majority of the time it could be kind of a combination of both because they can kind of lead to one another. And then labral tear. So we were talking in labrum. Your hip is a ball in a socket. Do you remember me talking about the shoulder as well? The only way that the shoulder is really going to stay within the socket, along with the ligaments and the dynamic stabilizers, which are the muscles, is the actual capsule. So the capsule, we kind of have a labrum. So over here is your labrum. So it's really, sometimes we see a labral tear in, it could be soccer players, goalies, anybody that has that funny end range movements or maybe do really quick, sharp turns, or if you have a history of the FAI impingement, we can also see labral tears. So they're all usually treated conservatively with a pretty good effectiveness as long as we can determine what the contributing factors are. So that's your bursitis, your impingement, strains and sprains and tendinitis is basically any of those muscles that surround that area. Your labral tears is that tissue that's in the socket. They're gonna have, somebody like that's gonna have a lot of pain with basically anything that pulls at the labrum. So if they bring the leg outwards into abduction, or if they externally rotate that leg out, that would actually pull that labrum. They're usually going to have a lot of issues there and a lot of concerns. With quick running, changing direction, things like that is where they're going to have a lot of their symptoms. So in the hip, remember we were talking about the fact that it's the joint that requires a lot of mobility. So you have to have really, really good range of motion in your hip. As an example, if you're walking or if you're running and you don't have a lot of hip extension, so as an example, if you're running and you don't have a lot of hip extension, what ends up happening, or when you're walking or when you're doing anything, what ends up happening if you can't actually get a good amount of hip extension, so see when I'm walking, my leg's actually pretty far back. If you don't have a lot of hip extension, you have a shorter stride because your leg can't go back so far. But what ends up happening is you tend to arch through your low back a lot more. And then you start to get some facet issues in your back. So a lot more overextension issues in the back. And then you have a whole spiral of low back issues, right? So mobility in the hip is super, super important, just to be able to manage the joints above and below it. And then when it comes to the knee, do you remember last night, for those of you who caught the session last night, your knee is the joint that needs a lot of stability. And where it gets a lot of its stability is from above and below. So your hip joint, right? Your hip has to be nice and stable when you're active and when you're on your feet. Otherwise, you start to get too much of that rotation, right? And then you end up with some knee issues. So we talked about last night, the muscles surrounding the hip. If you have weakness up here in this glute area, right, you're going to get more internal rotation. Or if you're tight in your adductors, a lot of them also internally rotate the leg. right? So you want to make sure you're nice and loose in through here. You've got a lot of flexibility in through those adductors, and you want to make sure that you have a lot of strength here to keep that leg rotated outwards, okay? And then same thing with the foot. The foot can play a huge factor too. Now, one thing that I always want to educate people on in the hip, who here has heard of your gluteus medius muscle? There's a gluteus minimus, probably the small one, gluteus maximus, it's probably the big one, and then there's gluteus medius. They're all important in their own way, but gluteus medius is basically the muscle that keeps your pelvis nice and level, okay? So it's a muscle that kind of comes like this. Now you kind of think of your hip joint as a lever, right? So if you were to stand on your right leg, okay, and if you had a weak glute on this right side, when you walk, when you squat, when you go downstairs, that muscle is supposed to keep the pelvis nice and level and basically does this downward pull. So if you're weak, what happens is it can't pull this pelvis bone down, so your pelvis starts to drop, okay? When you start to have that pelvis drop, the lever system is off, right? So when you get that lever system off, what ends up happening, if you think about it, this leg is going to be longer, right? If you try and walk with one leg longer than the other, you're going to scuff your foot. You're going to trip a lot. So our body has to, what? What do you do when something isn't working? You compensate. So what we're going to do is we're going to take our body and we're going to tilt it this way. So if I'm balancing on my right leg and I have a weak glute, instead of doing this, I'm going to do this. So you're going to see me lean, right? And as soon as I lean, what ends up happening is my spine is no longer straight, my spine is tilted. What you're going to see is that discrepancy in muscle tightness, right? So you've got a weak glute, your spine is tilted to the left, which means that all the muscles on the right side are getting shortened. So they're going to get really tight, and everything over here is going to get stretched and weak. So you're going to have this huge imbalance in your hip and in your low back. Everybody see that, right? Dropping the hip. Oh, I need to fix it. I'm going to tilt my pelvis upwards. So, and that's going to happen when you go up and down stairs, when you squat, when you go to pick something up, if you do, if you're doing exercises and you're doing a workout and you're doing one-legged activities, if you're running, as soon as you hit the ground on that right leg, instead of your leg dropping, you're going to lean your whole body to the right, you're going to tilt your spine, and you're just going to have a slew of issues, which are all treatable. Okay? So that's the effect of your glute. So your glute has a huge, huge, huge effect on your pelvis. Okay? So I kind of, I ask people, do you know if you have hip problems? Do you know your mobility? But what I notice with a lot of people is a lot of us don't have good body awareness. So when you move, pay attention to what you feel. Does something feel tight? Does something feel stiff? Does your left side feel different from your right side? When you squat down, a lot of people with a hip impingement, I know Miro, you said you have a little bit of discomfort with squatting and cycling. So if you get pain in the front of your hips with a squat, right, that could easily be a simple hip impingement, where a hip impingement is basically, so you've got your ball in your socket, right? And it basically means pinching of something somewhere. So if you're doing a squat, what you're basically doing is you're bringing your knees towards your chest, right? So you're doing this. So if the femoral head is, let's say it's not quite in the right position, if the muscles aren't keeping it where it's supposed to be within the socket, it's really easy for that front part of the femoral head to hit the top of that acetabulum, right? So that top of the socket, really easy. So a simple, if there's a muscle that's tight or if there's a muscle that's weak, so as an example, let's say your hip flexor is really tight and you've got some weak glutes. So you might see a little bit of like an anterior translation of that femoral head. It might have a little bit too much internal rotation. So with some stretching, with a little bit of external rotation strengthening, a little bit of, mobilizations, which we teach people to do at home all the time with some bands. All we're doing is just gently, trying to glide that femoral head into a different position to see if you can actually bring that knee up to your chest, or if you can do that squat, or if you can cycle without getting that pinching pain at the front. Yes, so what Miro is saying is when he cycles, it's not too bad during, but when it's after, they feel really, really tight. And they usually feel tight until he does and hears a snap or a pop. So do you remember how I said that hip flexor muscle or that iliopsoas muscle in the front aspect of the hip? If it's really tight, it can actually like kind of sit where it's not supposed to, right? Or if it's weak, it can sit where it's not supposed to. And sometimes people have a lot of discomfort until they hear a little click or a little pop, until it sits, and you're stretching it until it gets right into the groove where it's supposed to sit. And then their anterior or that front hip pain usually goes away. So two little things that I usually tell people to do. There's a couple little tests to see whether or not people are stiff and whether or not they're tight. So one thing that I always do is usually a 90-90 test. And what it's checking is the ability of a patient to be able to assess whether or not they can externally rotate their hip well or internally rotate the hip well. So I'll show you guys now. Now I do this with my patients quite often. And it gives me a lot of indication of what's going on. So front leg, as long as you have no history of major knee issues or that sort of thing. So your front leg is in front like this. So this is external rotation. So that hip joint is externally rotated and at about 90 degrees. Your back leg is in line with your body, but also at 90 degrees backwards. So that's what we call a 90-90. So hip external rotation and internal rotation, both at 90 degrees. Now, what you should be able to do is sit up nice and tall. A lot of us will actually find that they can't sit up tall. Now, besides the fact that you want to see if you can sit up tall, can you turn, can you twist, is pay attention to what you feel. Do you feel restrictions? Do you feel tightness? Do you feel stiffness in the hips? If you do, if it's in the front, your hip is stiff into external rotation. So that's something that you want to work on. If it's in the back, your hip is stiff into internal rotation. And then you switch and you assess both legs in both directions. Okay, so you can see on this side, my knee is higher. So I actually have less external rotation than I do on my left side. I can still sit up pretty tall, but I also do this with patients all the time. So my restrictions are pretty limited here. So that's the hip 90-90. Okay. For another test that I usually do is what we call a modified Thomas test. So we do this virtually, where we ask patients to lay flat, and all you're doing is bringing your knee up to your chest, and we're looking to see whether or not this leg can stay completely flat against the ground, or if it's like me and it pops upwards. So you can see if I let this go, I can have the leg down flat, but as soon as I bring that knee up, I get that little lift. Now, I have a history of left-sided or right-sided hip and SI issues, and I have a snapping hip. So I obviously have things that I need to work on with that. But you can see that my left leg could stay flat when I brought the knee up to the chest. My right leg could not. Okay? So we call that a modified Thomas test. Now, the last test well, I shouldn't say the last test. Another test that I do, which we talked about and we did last night, was a one-legged balance and a one-legged squat, which tells us a lot about strength and stability. So you balance on one leg. Can your hips stay nice and level? If they can you squat down? keeping your hips nice and level. And if you can, what happens to your knee? Because what happens to your knee is telling you what's happening with your femur and your tibia. Can you squat down with your knee nice and straight? Or do you have this happen? That tells you that there's some sort of instability or strength issue that can't keep that knee nice and straight. Should we be able to do a deep squat with one leg? No, not necessarily. Should we be able to do a mini squat as long as we have no major osteoarthritis, that sort of thing? We should be able to keep the knee nice and stable. Now, the other test that I do is basically kind of like a modified resisted test with the hip flexor, because a lot of us tend to feel like we always want to stretch our hip out, but sometimes stretching isn't what we need. It's actually a strength issue. So the strength issue, or the strength test that I test for the hip flexor is going to be, so I'm going to ask you, can you stand and lift your leg up to the ceiling? Not literally. And when you let go, can you hold it there? That tells you that your passive movement is pretty similar to your active movement, right? Okay, and if you do the other side, can you do the same? So can you bring the leg up, hold it there? Now, remember what I told you, I have a history of right-sided issues, right? So I can't hold it. So I'm gonna try again. I'm gonna bring the knee up as far as I can passively bring it. Passively is basically the ability of us to bring it up as high as we can in our end range. Now we're gonna bring that up, and I can't hold it there. But my left, bring it up and hold it. So those are a couple of tests that I usually do to take a look at people's mobility, flexibility, and strength and stability. Now, if you guys remember on my first workshop, what I talked about was physio, what we do, and how we assess on a virtual platform. So what you have to remember is, in order for us to feel good, our body has to be able to move. There's a certain amount of flexibility, a certain amount of mobility, and a certain amount of stability and strength that we're supposed to have. Just because you have an issue in an area doesn't mean that that's where your pain is necessarily coming from, or the cause of it, if that makes sense. There's always multitudes of variables that can contribute to your pain. If you have hip pain, I'm gonna take a look at your thoracic spine. I'm gonna take a look at your low back. I'm gonna take a look at your knee. And I'm gonna take a look at your foot. I'm not just looking at your hip. Why? Because our body is meant to move together. If something's restricted, we end up and we have to compensate somewhere else. When we start to compensate is when we start to have our issues. That's what physio is for, right? So with physio, our goal is not to treat your symptoms. Yes, of course, we want your pain to be less. We want your activities to be easier, but we want to treat and find the contributing factors that are leading to your symptoms. If I can fix the factors that are leading to your symptoms, you A, are gonna have a reduction in your symptoms, and B, they're not gonna come back. So remember, take advantage if you have a physio. If you don't, find one. If you feel like something's off, pay attention to your body, pay attention to how you move. If something doesn't feel right, ask somebody. Do a couple tests. Find out, ask somebody, and look into finding somebody to help you find out how to move better so that your symptoms go away and the pain doesn't come back, okay? So anybody have any questions about the hip? That was only supposed to be short, but I think I talked a little bit too much. So if anybody has any questions, feel free to throw it up in the comment section. And like I said, if anybody was here 2 nights in a row, can you throw a little heart up there? Because I want to see who came both nights, because I did 2 in a row. Tomorrow night I'm taking off, and Saturday night I'm taking off. So if you guys ever have any questions, as I always say at the end of the workshops, feel free to give me a call at the clinic. It's 905-576-5065. You can shoot me an email at admin@fundamentalsphysio.ca. You can follow us on Instagram, fun_physio, or you can follow us on our Facebook page. We do and just put up a YouTube channel last week. Somehow my non-tech savvy personality managed to do it. So we are hopefully going to have some fun stuff up there over the next little while. If you guys have any questions, even message me here. I don't mind kind of giving you some guidance and seeing if I can help you figure out what's going on with you. And stay tuned, Sunday night. If you or you know anybody who has any pelvic or pelvic health issues, postpartum moms, prenatal moms, anything like that, make sure that you share our workshop, because we'll be covering a little bit of pelvic health. There's so much to cover with pelvic health, so I'm just gonna try and keep it small, and just kind of discuss the common issues and why we have issues. So if you're somebody that suffers from, you know, leakage with coughing, sneezing, jumping, you can't run anymore, or you have pressure in your pelvic region, or pain, anything like that, feel free to check out the workshop. And if we get enough interest then maybe we'll do a little webinar to help you guys. So thank you. It was nice to see everybody. Thank you. It's Thursday, so one more day to the weekend, because we all deserve it. And to all of you moms that I won't see, friends, family, acquaintances, and all you other moms, happy Mother's Day. We see you, we hear you, and we are thankful for you. Take care and have a great weekend.